at this IMW, I have been asked to debate whether or not patients can get treatment-free intervals. And the reason why this is relevant in 2021 is because our field is really anchored on the notion of continuous therapy for a good reason. That we have several essential trials performed in the last 1 or 2 decades to establish the role of continuous therapy for both transplant-eligible and non-transplant eligible patients. What I want to highlight is that continuous therapy, however, has several caveats, including increased risk of second malignancies, as has been seen with lenalidomide, the astronomical cost of maintenance therapy. And what I think, however, is the biggest problem is that the approach of single agent maintenance therapy essentially treats all patients the same, irrespective of their risk of their intrinsic disease biology, and irrespective of the depth of response, because that's how it's done in clinical trials. So I believe now we have much better ways to choose a long-term therapy for our patients. And the one that is most, I think, instrumental is the assessment of minimal residual disease. Keep in mind that the foundations of continuous therapy were on studies or regimens that had very low proportion of patients achieving deep responses or MRD negative responses. And we know now that with modern therapy, triplets and quadruplets, we have an increasingly high proportion of patients reaching MRD negative response. And those patients tend to do very well, even in absence of continuous therapy, as has been demonstrated, for example, in the IFM 2009 study, where patients receive only 1 year of maintenance therapy. And most recently, we have also seen that on the part 2 of Cassiopeia trial, where patients who had a quadruple induction and consolidation followed by no maintenance had an outstanding long-term outcome that was not improved with the addition of continuous therapy. So I believe in the future, we got to be able to really look at those patients who are deep responders. That's going to be an increasingly higher proportion of patients, and really ask the escalation questions if those patients can do just as well without the burden of maintenance therapy. The other part that is very important is we have a bad habit of only emphasizing progression-free survival. And as long as the only thing we measure is progression, it's going to be very difficult to demonstrate that there's any particular subset that does not benefit from maintenance therapy. So the burden of continuous therapy has to be taken into consideration. So we need to look at outcomes that include, quality of life and cost of therapy. Otherwise, makes it a very difficult case for interruption of therapy. Moreover, the downside of maintenance therapy would evidently be of skipping maintenance therapy would evidently be the risk of early progression. So I think we have mitigating strategies that are available to us in 2021, including the close monitoring of disease by MRD, and hopefully in the near future by no invasive methods of MRD, that I believe will be able to show that can follow those patients and allow preemptive reintroduction of therapy without patients experiencing a full-blown progression.